Welcome to Dr. Jeffrey Roth's Looking Good and Feeling Great podcast, live from Las Vegas, with his co-host, Darrell Craig Harris.
Hello, this is Dr. Jeffrey Roth, your board-certified plastic surgeon in Las Vegas, Nevada, and we're back at it again.
Yeah, and you actually have a little son. Tell us where you just went to Mexico.
I did, and it was terrific. Shout out to Cabo San Lucas, not the crazy part, but the part where old guys like me kind of hang out. And I used to be the guy that would make fun of the guy under the umbrella. Now I am the guy underneath the umbrella. And I thought it was safe. We had this little cabana thing going on and stuff like that. And I got home and I wasn't so safe. So I got a little bit of sun on my forehead, which keeps creeping back, and a little bit on like my kneecaps of all things. So,
so you can make use of your awesome new sunscreen
I did. So and I exactly did that. And then the next few days I had no problem because I used my own, physician heal thyself. I used my own sunscreen and
shameless plug moment.
Shameless plug. Yeah, we didn't even get 30 seconds into it when we were with the same shameless plug. Wow. So but having said that, no. The sun is not your friend anymore. Please use sunscreen, and if you want a really good sunscreen, we have that for you. So
yeah, that's awesome. Today we're going to talk about complications with breast implants, and I was going to try to pronounce the words, but I'll let you do that because you're the professional.
So there's that's right. Yeah, we had to say Latin at some point.
Exactly.
I was thinking today there's a few things that can go sideways with any sort of surgical procedure. I was going to talk a little bit this time out with capsular contracture because we got a lot of calls and people coming in about that, et cetera, et cetera. So we're talking breast augmentation, which obviously is very popular here in Las Vegas, and Las Vegas has always been a big breast town.
No pun intended.
Pun completely intended. As far as that goes, and so it's usually
part of the look. And
it is the glitz and glamour that is Las Vegas, and we don't deny that. And oftentimes it can be the currency of some of these gals and the red carpet gals and the bottle service gals and all that sort of thing. Las Vegas is always there with L.A., New York, Miami, Dallas as your top 5, and we know that because the implant manufacturers tell us that because they keep tabs on how many they sell to plastic surgeons. Basically is usually things go really, really well with breast augmentation. There's like about a 98% happiness rating, which is kind of like unheard of with a
especially in surgery.
Yeah, with a surgical
elective surgery and that kind of thing.
Yeah, with a surgical procedure and that sort of things. And again, not to get into the Vegas craziness so much, but oftentimes with the servers, they'll say, "Oh, it's the best return on investment I ever did," right. Because their tips go up twice as much, et cetera, et cetera. So it's a strange phenomenon, but yes, it's a phenomenon.
Yeah, and you also have we talked about that the other day. Actually, you have the thing where people have body image issues. There's a lot of reasons why people get surgery, breast augmentation, right?
Absolutely. Folks that are a size 8 in the hips and a size 4 in the top, and they just want to wear a dress off the rack.
Sure.
Or they don't want to wear the chicken cutlets all the time. Or they've had 2 or 3 kids and kind of want things back where they used to be. So there's a lot of reasons for that. And, sure, we do people that you would know, and we do red carpet girls, and we do the bottle service girls and entertainers and all that. But then we do a lot of the soccer moms, and we do also do a lot of other physicians.
Yeah, because everybody cares about their body image. Right?
Yes, and especially in this day and age where we're all on camera nowadays, and even if you're not on social media, you're on camera in other places.
Zoom meetings
and all of it. Yeah. So having said that, people are much, I think, more conscious now than they have been. So having said that, it's a procedure. We like doing it. People like getting it. It's usually a real good procedure, but it's part of our mission, if you will, to tell you the good parts and the bad parts. And so that way, one, there's no surprises. And then 2 is you can make an informed decision that's good for you.
So when you do breast implants, there's an actual, your body basically builds a capsule around the implant. Right?
Exactly right. So anything you put into the body, anything that humankind puts in the body, we can't make it as good as God can make it, right? So step 1. So whether it's breast implant devices or defibrillators or chemotherapy ports, whatever we put in, the body's going to wall it off a little bit and say, hey, that's not me.
It's a protective.
Exactly. I'm going to go ahead and wall that off. And it walls it off with this thing called capsule, which is a collection of cells that kind of walls it off. And usually capsules are nice and soft and happy, et cetera, et cetera. But sometimes capsules will go ahead and harden up and kind of contract themselves up a little bit. So you hear capsular contracture or CapCon or capsular scarring, and so those are the kind of terms that we
and the term scarring, of course, scares people, but actually in that situation, it's sort of a natural.
Well, right. So so usually the capsule's fine, and then when you start going ahead and getting contracture, then yes, you can call it capsular scarring because that's what scars do, is they contract.
Right.
And when we're in the burn unit, we really fight against scar all the time because you don't want to have contractions, especially around joints.
Right, limits mobility.
Limits mobility of hands or shoulders or necks or any of that kind of stuff. And so I thought it was always appropriate, and it's kind of an inside joke to plastic surgeons, especially, and surgeons in general, is that one of the biggest Disney villains of all time was this cat named Scar.
Right.
So we thought
it's
that
evil Scar.
Evil Scar. So Scar has been a villain in my life for years. And
that's
years.
I mean, even when you do these kinds of surgeries, not only breast, but every kind of cosmetic surgery, scarring is always a big part of the discussion. Right?
Of course. Yeah. Whenever you go ahead and make an incision through the dermis, by definition, you're going to create a scar. Okay. So that's the way that the humans go ahead and heal up. Now, there are some very, very smart people at UCSF and at Stanford and NYU, other places that are trying to do scarless wound healing. And they actually, this is kind of old data, but the last time I checked in with a few of those folks up there on the peninsula and the city in San Francisco, they actually were able to do scarless wound healing in fetal sheep. Okay?
Interesting. Wow.
So how that came to pass is basically is a fetus sheep is similar to the humans in that regard. And the reason why they're using fetal sheep is because of cleft lips and palates.
Oh, okay.
So what they're trying to do is be able to operate while the baby sheep is actually in the mom's womb. So you go ahead and you sew it all up together, and they get born without a cleft lip and a cleft palate, which is wild, one, and then two, no scarring as well. And so that's kind of how far we've gone as far as that goes. And they don't know if it's the milieu of the mom's womb or
what helps the healing process.
Right. So whether is it a sterile environment? So what causes all that? And then of course how to apply that to humans, and then humans that are outside the womb is obviously two next big steps. But yeah, they have been able, from what I've read and talked to the guys and gals, is achieve scarless wound healing if you're a fetus in your
so with the capsular contraction, what happens when that happens, and what issues does that cause?
So basically there's a scale, right? There's a scale of everything, right? So there's 1, 2, 3, 4. Dr. Baker came up with it. So 4 is kind of like a rock, really hard as a rock. 3 is a little less so hard, but not really like a rock. 2 is, well, it's a little bit harder. And 1's like, well, it's not exactly perfect, but it's
maybe one side's hard, one side isn't hard.
That happens all the time. Yeah. So sometimes you get both of them in that are hard, or one will be a 4, one will be a 2. So first of all, is a diagnosis is, okay, is it harder or not? Okay, so that's step 1. Step 2 is, how hard is it? So what's the Baker classification on it? Okay. 4 is basically all go to surgery, right? Because they're just rocks. And
Sure.
1s, 2s, 3s, oftentimes you can go ahead and try some conservative methods. And by that, I mean, massage is always good. There is a breast physical therapy place here in Las Vegas that we like, and that can be helpful.
Does that sort of loosen up the tissue a little bit?
Yes, it can. Yeah. Or sometimes they have spasm on top of that. So sometimes they can get you out of spasm of the pectoralis major muscles. So that's one thing to do. Sometimes we can do things medically, which means Singulair. So it was first Accolade and now Singulair. What Singulair is, and many of you are listening at home, is it's an asthma drug.
Oh, okay.
And what they found, it was kind of an interesting story, is told to me, is there was a pulmonologist, allergist, I can't remember, but he was giving out Singulair to his patients. And some of the gals that had breast dogs says, by the way, my breasts are softer. And he's like, what?
Oh, interesting.
So he went across the hallway to his plastic surgery friend. I was like, does this make any sense? So with that, it was interesting because that gets into the etiology of, well, why? How does this happen, right?
Sure. Yeah.
So the incidence is between 17 and 27% of folks will get some sort of capsular scarring or capsular contracture. Okay. So the next thing is okay, well, why? Nobody has a real 100% why for this. So
it could be immune system. It could be a lot of different.
Could be a few things, right? It could be blood in the pocket. Smokers tend to have a much higher rate of capsular scarring, capsular contracture.
Right. And they have blood flow issues. And
yes, yeah, all of it. Smoking's evil. So if you're smoking, please stop.
Stop doing that.
Please stop. Throw the cigarettes out the car window now. Okay, good. So I'll get letters on that. Emails. So that's all where that is, and then so the singular. So basically, again, it gets into the etiology of what makes the stuff. And some of this is they think it's biofilm. Now, what's biofilm? Biofilm is when you go ahead and you put an object into the body. Right, there may be a couple of bacteria floating around. So as sterile as you can be, et cetera, a couple of bacteria. Right. So and then you kill the bacteria off with antibiotics. Not a big deal. But sometimes the bacteria will go ahead and make this biofilm, which is kind of like the house they live in, and so that has been implicated in the capsules that come out, because this is the bane of plastic surgeons' existence when it comes to breast augmentation is capsular contracture, right? So if we can go ahead and cure or prevent this, boy, that'd be great. And so that's one thing is the biofilm. That's why we go crazy with the antibiotics. That's why
as sterile an environment as possible.
Absolutely. And I am a little more nutty, as you can imagine, is I actually
I didn't say that.
Lock my you were thinking it. I actually lock the door to my OR so people don't walk in and walk out of my
that makes sense,
because there was a study I think in the Netherlands that they actually counted how many times the door opened and closed, and then they saw a correlation with infection, etc.
It's actually funny because as just as a layperson, not a surgeon, obviously, like it's funny to think of somebody coming in and out of the door when you're doing surgery.
Well, yeah, I mean, a nurse will come in, nurse will come out, so tech. But having said that, I put up a sign to block my door. They think I'm nuts, but that's fine. So the nurses tolerate me. So we do all of that now. To go ahead and try to prevent all of this stuff as well. And in prevention, of course, would be, massage and all that. But getting back to, okay, so now we've set everything up for success and hopefully not have a biofilm and hopefully all that. Now, why does the singular work, right? So in the capsule itself, there are all sorts of different cells, right? So one of the cells that hangs out in the capsule is called a myofibroblast. Myo meaning muscle, right? So this myofibroblast sometimes will go ahead and contract a little bit. I mean, we're talking micro, right? A little bit. So the singular works because the same receptors that cause bronchoconstriction also cause these myofibroblasts to constrict as well.
Oh, interesting.
So if you can block those with, if you think about it, you block those with the singular, get things to open up in the bronchial system, you go ahead and you hit these same receptors with a myofibroblast, and so sometimes you can get things to be a little bit softer. Right. So, but again, a conservative approach, meaning medicine, a massage, et cetera, sometimes can get people by. Also, some folks like ultrasound to the breast. You have some conflicting reports with that as well.
So how would that work? What's the concept behind that?
Well, that's a good question. That's where you get a little bit of fuzzy in the
a little experimental.
A little fuzzy in the literature as to exact mechanism. They think they can realign the cells, et cetera. So, and we've had a couple. I don't have it in my office, but there's a few folks in town that do, and I don't hesitate to send folks over there. And we've had a couple folks with success from that. Again, it's hard to argue with success.
I mean, really, too, if you can avoid having to go back in.
Right. Well, that's the thing. So, and again, like any surgery, reoperating surgery is usually no fun because it's usually there's scar there. You don't see every plane the way you want to, and et cetera.
And it's usually, life happens, things happen.
Right. And it's usually a surprise, and people don't like surprises, especially after surgeries, et cetera. Yeah. It's something that we all, from a surgery standpoint and from a patient standpoint, that we want to avoid. So those are sort of the things that we see with capsular scarring. Can we prevent it? And take all the steps we can. If we do wind up getting it, again, what's the diagnosis? How bad is it? And then, again, how can we treat it? Can we treat it conservatively? And if not, now do we have to go back to the operating room? Okay.
Right.
So if we go ahead and we say, all right, we've tried everything, et cetera, but boy, they're still hard, time to go back to the operating room. Now, sometimes we have patients, and it is always a bit of a surprise, but not really, because you live here in Las Vegas. And some folks have had breast implants in since the 80s.
We spoke about that, and people don't realize that actually those do need to be replaced.
Yeah. So again, getting back to the, man can't make it as God can, is at some point when you put something in the body, it usually has to get backed out. My orthopedic friends will tell me, plates and screws, have to come back out. Defibrillators usually have to get switched out. So at some point, usually things have to get switched out.
What's the time frame on that? A lot of people do know that, but a lot of people don't know that.
Yeah. So the old school thought of that is you got to replace the implants every 10 years. That's not exactly true anymore. Now, that used to be true in the 80s and 90s, where you had the old silicone implants that had a leak rate of 50% at 10 years. So you had a 50-50 shot at 10 years. So that's why I take them out. Nowadays, that leak rate is down between 5 and 10%, depending on who you read, et cetera, et cetera. The implants are better. It's the cohesive gel or gummy bear implant.
Doctors are better.
I like to hope so. Although I'll never be I'll go on record, I'll never be as good as the guys who trained me.
Well, yeah.
100%.
But also that also comes back to the board certified aspect.
Yes. So yeah. No, I got trained by some giants and they made a mistake and let me in and actually let me in. And every day, and every day I try to emulate these guys. And I do. And I say, okay, well, what would Dr. Mathis do? What would Dr. Hoffman do? What would Dr. Randy Sherman do? And okay, I'll do that.
And those are actually globally known.
Yeah. So and just, they're spectacular surgeons, and also they're the spectacular people. I got really lucky as far as that goes. Now, I've ran into a couple of surgeons who trained me who are spectacular surgeons, and bedside manner can be a little lacking, but those are the old school guys. But having said that, but you learn where you learn, and that kind of thing.
Well, and the thing is, we talked about that too. You want the best surgeon. It's not about a personality thing so much. Ideally, of course, they're great. Ideally, and you get along, but you definitely want the board certified person who has lots of experience. That is the goal, right?
Yeah. So that's kind of the gold standard for sure. So if we have to go back to the operating room, basically, all right. So now what are you going to do, Doc? So one is typically you would take out the old implants, okay, and then do what's called either a capsulotomy or a capsulectomy. Okay. So a capsulotomy. Otomy means make a hole in it, basically, right? And capsulectomy means take it out, okay? Ectomy. So appendectomy, pancreatectomy, ectomy, right? Take it out, okay? Yeah. Again, getting back to my Greek and Latin.
Well, that's actually, because we always hear those terms just as normal people, but it's nice when you actually explain it. I think that's one of the great things about this show is that you can explain common terms. There's really no dumb questions.
Oh, yeah.
I'm the dumb question guy.
No, there is no doubt. And I say that all the time. I will never be offended by a question.
Right.
So because again, if I'm not a plumber. Shout out to the plumbers and everything else like that. But that's their line of work, and they go to the plumbers meetings, they go to the plumbers conventions, and and the people that
learn their craft,
and the people that like their craft are better at it because again they're reading the technical journals or they're talking to other guys about what's the latest thing. And again, everything's come a long way. I just had to go ahead and get toilets fixed at the house. Now we're on toilets fixed at the house. I don't know how we're going to index this.
We'll figure it out.
But very long story short, this guy came that if one of the major hotels here can't figure out their toilet, they call him. So he's like the super duper guy. And he basically went ahead and took this very long thing. It looked like a very long colonoscope. And went ahead and put it down there. So, oh, here's the problem. So it's again applying medical technology to plumbing. And so again, these are guys that have embraced technology and worked for it, et cetera. So,
and it's nice to know that keeps moving forward.
Right.
There's always new, and there's new procedures, there's ways of doing old procedures, right?
Yes. And again, the microsurgeons are going by leaps and bounds. The general surgeons also, they can go through one port in your belly button and do these big surgeries. It astounds me how far all that stuff is going from whence I originally started doing surgeries, et cetera, et cetera. So getting back to capsulotomy versus capsulectomy, right? So otomy means make a hole in it. So if you can, especially in these gals, especially here in Vegas, they're very fit, they're very thin, and so you want to keep as much soft tissue as you can inside. Right. So if you can make holes in it, by holes I mean kind of these incisions, these kind of linear incisions to kind of free up things and kind of expand it out like
as natural as possible.
Right, and to expand it out like an accordion. Gee, that's great. Okay. And then you wash the heck out of everything and then put an implant in back, et cetera. So that's the capsulotomy part. Capsulectomy. And so sometimes you have to do the ectomy. You have to take it out if it's really socked in. Some folks have this calcification, like an eggshell calcification. And these are usually my old school Vegas, models or showgirls that have had silicone implants in for 30, 80, right, for 80s, 30. And that, that they've been leaking for decades.
Right.
And so you get into that, and then that's a whole different story. Yeah. And so that obviously has to come out, et cetera, et cetera. So, so that's.
Do you find when people in that situation, when they have them take them out, do they often want them replaced, or what?
Yes, actually, that's a great question, because if you asked me that question 10 years ago, I'd say it was 99.9%. Nowadays, there's a significant portion of those folks that either opting for smaller, okay, like 25%.
They're not really working in that
right. So their professions anymore. Right, exactly right. So they're like, oh, these were great. I had them, I was in, Jubilee, I was in Lido. Sure. I said, but enough already. I'm like, okay. And so, and for those gals, one is they don't want to completely change their dresses and their wardrobe and all that kind of stuff. One, and then two is they've been busty for so long is to go completely kind of flat. They're like,
they want to try to find a middle ground.
I want some upper fullness. Now, having said that, there are some folks that say, okay, doc, they were great while they lasted. Enough already. I want them all out, and go ahead and do that. And then you talk about, all right, do you need to do a lift, et cetera, because sometimes you've been stretched out for so long over the years, and you want to lift things up and make them look perky.
Yeah, because it's not just as easy as just taking them out. I mean, if they want a good, reasonable look. And,
So again, everybody's different. So some folks that just did a small implant, sure, they can get away with them taking them out and kind of seeing how the tissue retracts back.
Sure.
Some folks, actually, what can be really interesting sometimes is folks with old school saline implants, and they want to downsize. Some folks, and you really have to trust your patient, will go ahead and on purpose deflate the implants.
Oh, interesting.
Sterilely, of course.
Saline.
Don't do this. Kids don't try this at home. And yet, it's certainly not silicone.
Yeah.
Please,
that's another subject.
Please, but then downsize them, and you do get some shrinkage of the soft tissue, which is kind of interesting. But you got to really trust the patient, and two, you got to have like a date of 2 months where to go back.
Yeah, I mean, a big part of that probably too is really explaining what this is going to look like after they take the implant out, like giving them realistic
expectations. Absolutely, and again, everybody's different. I mean, yes, on our website. www.jjrothmd.com, we have befores and afters, and more and more people are coming in, so we're going to have more and more befores and afters on there. But having said that, is usually with the lifts afterward, we usually make them look pretty nice.
Right.
So different, but nice. So with a capsulectomy, oftentimes you'll have kind of this raw surface, and so sometimes we'll go ahead and put drains in. And they usually come out in a week or so. Right. Not for blood, but basically for the stuff called serum, which we've talked about before. The serum is basically the same fluid that you see in a blister. That kind of
it's
thing.
your body kind of
right, because you've come up with some raw cells, and they'll kind of leak that fluid in there, and then usually that'll come out. So that's kind of the long and short of capsular scarring, capsular contracture. Now the other thing to do is pockets, right? So if somebody is on top of the muscle, remember we're making a pocket in the breast, so you can put the pocket either on top of the muscle or underneath the muscle. We're talking about the pectoralis major muscle. So some folks that have had a big capsular contracture, and once you've had a capsular scar or capsular contracture, yes, you're more apt to have it. So some folks' philosophy will be, let's get to virgin tissue. So if you're on top of the muscle, hey, let's switch it to underneath the muscle.
Right, just try a different path.
Right,
yeah.
So that's interesting, and we've done that. Some folks talk about texturing of the implant as a way to decrease capsular contracture, and I think that used to be true before, but in my readings, if you take the implant and put them underneath the muscle, that advantage goes away of textured versus non-textured.
When you say textured implant, how would you do that? What's the process?
Yeah, so they come out of the box. They're either smooth or textured.
Okay.
So which gets us into...
So it's almost like the frosted glass.
Exactly, right? And so some have more aggressive texturing than less. And in my hands, what I've seen is some of the texturing will also caused some more seromas, et cetera, et cetera. So I wasn't ever a big fan of the textured. And now textured has been implicated in some forms of ALCL, et cetera, et cetera. So thankfully, I think I've sidestepped a lot of that with the smooth implant. So, but having said that, so there's the choice of implants, there's choice of pocket. The other thing is like, doc, I've been through this 5 times before. How can I best have my chances go the way I do? And there's this stuff now called acellular dermal matrix, or ADM. Okay, what's that? So ADM is basically dermis that comes off of the shelf, right? Which has always been the holy grail in the burn units, right? Because the burn units, somebody comes in with a 50% burn. You don't want to take 50% of their skin to cover the 50% burn. They have a 100% wound, right? So in a perfect world, you would go ahead and, let me get the skin off the shelf. And you go to the shelf and you put it on. So there's different types, et cetera, but basically acellular dermal matrix is basically dermis. Dermis, as you know, is the strength layer of the skin. That's where tattoo ink goes, et cetera, right? So now we're able to take this dermis and kind of put it on the skin in the burn units, and then we've been using it, we plastic and reconstructive surgeons have been using it more and more for breast reconstruction.
Interesting.
And now we're using it for breast redos, right? Because we're almost at a reconstructive point with some of these patients.
Because every time you go in, it creates some more scar tissue.
Right. So it's just, you're trading scar for scar. So what this does is you go ahead and you say, all right, we're going to make ourselves a new pocket, and I'm going to go ahead and put this stuff in this acellular dermal matrix. Why would you use that? Well, a couple of reasons. One is it adds a little bit of we're talking millimeters, but thickness, which may be very helpful in those folks that are really, really skinny, okay, and don't have a lot of fat, the gals that work out a ton, et cetera.
Right.
And you can see rippling. So it's especially
because rippling is a big issue with that, right?
Reels is a big issue too, and there are some girls that are just so darn thin you can like read the lot number, through the skin.
Yeah, it's interesting.
Right, but having said that, so you go ahead and you put that in. So one, that's good for rippling and good for real skinny girls. But 2 is the capsule is not supposed to be able to crawl over this acellular dermal matrix.
Oh, interesting.
So for those folks that, for whatever reason, have a propensity to do that, you can put the stuff in there, and so that usually will go ahead and keep them soft. The downside, it's a little bit more expensive than the average bear. I mean, if it was $25 a sheet, I'd use it every day, but it's a bit more than that. So then you have to have a real conversation with the patient.
Yeah, maybe for somebody who's more high risk at having those issues.
Yes, pluses and minuses. That's why we plastic surgeons don't do it in every single case. We're like, doc, if you won't prevent one, you're like, well, it's going to cost. Yeah. So, but having said that, hopefully as time goes on, the cost will go down, or there'll be competitors in that space, and then hopefully we'll be able to go ahead and make that
cutting edge, right?
More available. Yeah, again, if you asked me 5 years ago, I'd say yes, but now it's getting to be more and more commonplace, and we've been using the same sort of things for abdominal wall reconstruction. Before, we used the stuff called Proline, which was great for what it was. But sometimes it would be, you'd have some edges or corners, or sometimes it'd be a little firmer. Now we've gone to more biologics, meaning stuff that would eventually fade away.
Less complications.
Yeah. And some of this stuff is a stratus for a little while, and then it eventually will go ahead and fade away. So there's a few. There's a few products out there that do just that, which are really good for those folks. Again, really skinny folks that do big implants, and the implant starts sliding down the chest wall. Well, sometimes the tissue just isn't going to hold up for that. So sometimes you put in this biomesh, if you want to call it, to go ahead and use it as a shelf or a buttress, so it doesn't quite slide.
So almost like, not really like an internal bra, but something like that support. Right?
Some people call that call it that. Okay. So. You've been on the web. You've been looking.
Hey,
I
watch Botch.
Yeah, you're an expert. So absolutely. But having said that, yeah. So there are new modalities, and there's more stuff coming out all the time for this thing because it's an issue, and so there's an issue.
It's great that
need,
there's so many options. I mean, I remember we talked about that briefly, but my mother had breast implants in the 70s, and she had leaking. She had basically every problem you could think of, reconstruction. So it's so nice that has progressed to where we are now.
The folks that are doing the reconstructive now are just doing phenomenal work. They're using the acellular matrix in ways that would have been sacrilegious. They would have been an automatic fail to go ahead and have somebody go through a breast cancer and a mastectomy and trying to make them whole again. And we used to have to go ahead and lift up a whole bunch of muscle and swing muscles around and flaps and stuff. And sometimes we still do. But oftentimes folks now are putting an implant underneath this acellular dermal matrix on top of the muscle, which again would be an automatic fail when I was taking my boards. But they're doing it, and they're getting good results, et cetera, et cetera. And so, again, it's pushing the envelope. And then some folks are actually doing free tissue transfer, meaning that they're taking tissue from one area and plugging it in to the other area, making breast out of it, et cetera, Angelina Jolie, et cetera, et cetera.
Sure. Which is, in a lot of ways, is a more natural option.
Phenomenal. Yeah. So, again, you have to make it fit the patient. And, are you a candidate for it? What does your body habitus look like? And see really kind of what fits you.
Have you dealt with a lot of breast reconstruction from cancer, that kind of thing? Is that part of what you do?
Sure. No, it's funny because in general surgery, where I was for 7 years, we did lumpectomies and we did
You're doing everything, right?
And mastectomies and all that stuff. And then as a plastic and reconstructive surgeon, you're reconstructing that. Mm-hmm. So not only are you making the holes, you're filling the holes as far as that goes.
And that's life-changing for people.
I mean, the diagnosis itself is life-changing.
Of course.
And when you're in the room and you have to give this diagnosis, oh, by the way, you have cancer.
Right.
After the word cancer, they're out. Okay, they're not listening to anything else you're saying, and you have to realize that.
Yeah.
And then again, shepherd them through this process. And medicine is doing a much, much better, I think, job of that. The other thing is also making people aware that there are reconstructive options.
Yeah, because it's not just the cancer diagnosis, which obviously can be devastating, but then it's also when you get past all that, hopefully you do, and you get on the other side of it, you want to be able to offer them a positive option of reconstruction.
Absolutely. And we talk about immediate reconstructive versus delayed reconstruction. And actually, there's a law in New York that if you give a diagnosis, I forget the diagnosis or what the trigger is, diagnosis or actually schedule a mastectomy, you have to go ahead and give them information on reconstruction.
Oh, that's great.
Because a large percentage of folks, and especially in the underserved communities, the black and brown communities, they did not know that. What do you mean I can get fixed? What do you mean? And here's one for you. And we in Nevada were one of the first to go ahead and mandate that insurance has to pay for reconstruction.
That's great.
And they have to pay for the other side because the insurance, we'll pay for this.
Because you really need to do the whole journey. You can't just do part of the journey, right?
Right. So having said that, one, I think that more people know about it, thank goodness. Two, that insurance companies now will go ahead and pay for it. And again, make these people whole. And when I used to do that, when I came back to town, it was very, very rewarding. It was really spectacular. The implant pack.
You want to give them light at the end of the tunnel.
Yes, exactly right. I mean, they had it, bad enough, obviously, with what they had to go through. But to go ahead and give them some reconstructive options and give them some hope, that's always a really cool thing.
Yeah. So obviously, as men, it's hard for us to really completely relate to that. But for women, obviously, breasts and every part of your body is a really important part of who you are.
Right. But it's an emotionally laden part for sure and forever. And parenthetically is men get breast cancer too. Mm-hmm. And about 1 in 100 will go ahead and do that. Now, they typically don't need as much reconstructive option per se, but still, you go ahead and you have that conversation as well. So,
if a woman has a concern about they might have that issue with the contracture, like what would be the first thing they could maybe kind of look for if they have a concern? I mean, obviously, you need to get it checked out.
Sure.
But if they're just at home and they're doing an exam, what should they be kind of looking for?
Well, basically, are they as soft as they used to be? And things will change with breasts over time, et cetera, of course. But, and breast capsular contracture, it can occur early or it can even appear later, years later.
Right.
So, and sometimes it's secondary to trauma. For example, somebody will have a trauma and hit their breast, and the capsule may go ahead and open up or lacerate a little bit, and you have a little bit of bleeding in there, and that may be the nidus to set off capsular scarring. Yeah. And so, and they may be micro trauma. Who knows?
Yeah.
But by and large, if there's a firmness, if there's something that's uneven, if whatever that is, if there's a question, go see the doc.
Yeah, and it kind of relates to the breast implant illness that we've talked about before, that people have a lot of concern about that. So, like, if you have issues like that where you feel like something doesn't feel right, like, please go see somebody professional.
Right. Absolutely. And the other thing too is again, trauma. Usually the implants hold up pretty well, although, so yes, they can option in trauma stuff. Capsule or even working out, sometimes you can can go ahead and do that. Another older treatment for capsular contracture was closed capsulotomy. And what that means is, and the older guys used to do this, is basically you just squeeze the heck out of it until you get the thing to crack.
Oh.
Okay, which is not really in vogue anymore. One,
try to explain that to a patient,
right? Probably, hey, this is what we're going to do.
Yeah,
so
exactly.
one, and then two is that's step one, the crack thing. Two is some of these guys, they used to have actually instrumentation that looked like one big kind of nutcracker, or actually a couple were like the size of, you have to cut off the lock in your junior high school, right? Because you have a combination, something like that. Say, excuse me, Mrs.
Ouch.
Jones, I'll be right back. Yeah. So, and they come in with the room with something. Yeah.
Sure.
No.
Yeah.
So that thankfully has kind of fallen out of favor.
Yeah.
And
went the way of the Middle Ages.
As again, we have, and now we have Singular. Now we have some more conservative treatment,
better options
to do that sort of thing.
If people want to contact you to ask questions about this and actually any other plastic surgery, medical, how can they find you?
Sure. They can find me on the web, which is www.jjrothmd.com. We are all over social media, from Instagram to Facebook to LinkedIn to Twitter to all that kind of good stuff. All the .com, right? So by all means, get us there. Or we still use the phone. So by all means, go ahead and ring us up at the phone, and we're happy to answer. We love questions, so we're happy to go ahead and answer questions. And that phone number is 702 area code 450-0777. And if you have a question, again, there's no penalty for questions. We're never mad at a question. By all means, give us a call, let us know, or an email.
And also if there's a subject that you'd like us to cover in the podcast, please let us know that too on social. We're happy to find new subjects to talk about. There's obviously things that are sort of in fashion, in vogue, but then there's always new things that we may not be aware of. So if you have concerns, let us know.
Yep, absolutely. So fabulous.
Awesome. Well, enjoy your suntan.
Well, thank you. Fleeting as it is,
and I
trust me.
should say, actually, we were going to talk a little bit about this. I kind of brought it up about the vaccines. So you actually have been vaccinated as a first frontline. Yes. Doctor.
Well, a couple things with that is I was the last of the first tier, meaning that I don't go to the hospitals very much anymore. So, yeah. Right. So basically, I made sure that everybody in the hospital went before I did. Right. The guy pushing the mop because he's in the COVID rooms, I'm not. Exactly. The guy, in the cafeteria, they're all important folks. So they all went first. And so I made sure that if everybody went first, then I'd go. And then I got my stuff done. And then was the second tier and the third tier and all that. So yeah, so for me, I was a bit hesitant at first, but the more research I did on it, the more that I talked to doctors, it makes absolute perfect sense. And frankly, it's our way forward to go ahead and do
and
this.
And you're interacting with patients. You're doing all that,
so we're
it's
always
better for everybody.
Yeah, so we're always interacting with patients, and we're always there. And there was one plastic surgeon actually. Who passed away in Beverly Hills. A patient coughed on him while I was doing Botox, and that's all it took. And he wasn't vaccinated yet. And so, a very popular, successful guy. And this virus doesn't discriminate. Old, young, and different groups will get it worse.
Did you have side effects? Because that seems to be a really common concern.
No, so did not have side effects, and we can joke about all the different side effects that we can. But basically, for me, it was like I got the Pfizer, and it was a punch in the arm. It felt like a punch in the arm. Right. And then now a couple of my doctor friends, yes, they had fever. 24 hours later, another guy felt really
just for a day or so.
Yeah, felt really tired after the second dose. The day after. And so you're going to get a little bit of that, but the downside of not having the vaccine, in my opinion, is death.
Especially if you're dealing with the public, right?
And you're dealing with the public. And there are people in our community that have had it and have wound up really. They're long haulers now, or they're really messed up, or they can't go to work, or they've died. And these are terrific folks, and it's just an absolute shame. Right. And
so we're fortunate that we're able to now starting. I think pretty soon everybody's going to have, the general public's going to have access. But I think it's good to talk about the side effects because there's a lot of people that do have concerns.
Absolutely, and not to, and we don't joke about or take them lightly. That's why they have you sit around for 15, 20 minutes to make sure you don't have anaphylaxis. That's why you just kind of make sure. By all means, ask questions. It's okay to ask questions, and then let's get some science in front of it.
Right. So, and I would encourage everybody to look online. There's a lot of ways you can sign up to get that. Actually, even Walmart.com pharmacy has that. So please encourage everybody, your friends and family, to check that out. I think it's important.
Yes. So yeah, I think it's our way forward to finally getting back to Golden Knights games and finally
getting back to the fun.
Yes, and getting back to, frankly, as selfish as it may be, is getting Vegas back to being Vegas, because we love people here in Vegas. This is what we do really well.
All about people.
Is hospitality and making some memories, and they go back and I had this great time in Vegas, and that's what we've done best for 100 years.
Yeah, so. Awesome. Thank you so much, everybody, for joining us, and please find us again on social media. Find Dr. Roth at jjrothmd.com, and we look forward to seeing you next time.
Sounds good. See you guys soon.
Thank you.
Thank you so much for joining us. For further information, please visit the podcast website link for Dr. Jeffrey Roth. See you next time.